And one topic, which is going to be the central point of our focus for today's interview, is one of the biggest areas of the oral health and also brain connection and overall body connection, and that's of sleep apnea. So 22 million Americans suffer from sleep apnea, and yet many who have it never get diagnosed. And there is the traditional sleep apnea that a lot of people think of, an overweight, older male often, who has the classic signs of being overweight and other challenges that a doctor might recommend that they get a sleep study, and then would prescribe like a bunch of interventions, including like a CPAP machine. Mm-hmm. But there's this whole other category of sleep apnea that dentists like yourself are really bringing to the forefront. So help us understand first with the basics, what is sleep apnea and what's actually happening in the body when somebody has it?
Right. So sleep apnea came to me directly via, getting a diagnosis for sleep apnea. That was about 10 years ago. And I always try and think back to what I thought of sleep apnea, which was very little recognition of it, to what I know now, because it's hard to know and remember how a lot of people feel about this, including physicians and dentists and other healthcare providers. And that is that it's really not that big of a deal until it becomes a big deal. But it happens much earlier than that. I think I've told you before that dentists are able to recognize sleep apnea decades before a physician can, because we're looking at a whole different subset of signs and symptoms. And we can talk about that if you want.
You're going, in functional medicine, they call it, you're going upstream,
yeah,
and you're seeing certain upstream factors
right.
that are causing
Yes, and the further upstream we can go, especially in sleep apnea, and going upstream by decades is a huge deal, because that liver damage and brain damage, that starts happening at an early age. It can even happen, with children, infants. I see sleep apnea and other sleep disorder-related breathing issues in infants, and that affects development. That can affect their brains. It can affect their personality, learning disorders. It's a very broad subject. So upstream is important in this regard.
So when you talk about upstream issues with sleep apnea, so we talked about the classic case, and mostly people would, let's say laymen, would look at sleep apnea and say that somebody might be a candidate or have a risk for it when they are overweight. That's often the big one.
Right.
So when you're going to these upstream factors to look at sleep apnea in a patient, what are the things that you're paying attention to that are part of the way that you look at sleep apnea?
Right. So that's a good question. And it's mostly in the mouth, or at least from the neck up. Of course, I have a list that I check off list that I go through, and I do that with every patient, because I assume everyone has the potential for any kind of sleep disorder breathing issue. So as I go through the list, there's the usual stuff on the list that physicians look at: comorbidities of sleep apnea, like high blood pressure, nocturia, going to the bathroom in the middle of the night. There's a host of other things: high blood pressure, heart arrhythmias, insulin resistance. But when it comes to the mouth, if you are struggling to gain air at night, there are things that happen in the mouth well before the effects of not being able to breathe at night and having hypoxia and slowly getting brain damage and the heart working harder than it needs to at night. That all has a delayed effect. The good news about the dental ramifications of sleep apnea, the signs and symptoms of someone struggling for air, is that we can see them much earlier. There are many. There's gum recession, abfractions where the side of the tooth is breaking off, calving, I call it, calving of the dentin, sensitivity in those areas to hot and cold, bruxing, sleep bruxism is the term now. That's bruxing at night, grinding, clenching your teeth. It can even be just a clench, not a grinding motion. TMJ, sore muscles, headaches in the morning.
Dry mouth you were talking about?
Dry mouth is a big
how many
one.
people have dry mouth?
Well, if you're older, a lot of people have dry mouth. If you're on medications, a lot of people that are taking medications, that's a very common side effect of most pharmaceuticals, have dry mouth. But there are a lot of young people that if their mouth is open all night long, they're going to have a dry mouth in the morning, a sticky tongue. It's going to be they're going to be thirsty at night. So dry mouth is a big one. A scalloped tongue, high Malin-Patty scores. Actually, physicians look at that as well. It's a combination of so many different things that if it all starts fitting together, then we realize there's an issue. Mouth breathing, of course, is a problem. A tongue tie can cause an issue with breathing at night, the positioning of the tongue while you sleep. if the patient can't breathe through their nose, that's again mouth breathing. That's all signs that something's going on. We also look at facial development. That's what I was referring to from the neck up. I can look at someone's face profile, full frontal, and make some assumption as to what the size of their airway is, what the size of their sinuses are, whether they're able to breathe or not, lip posture, tapering of the chin. We have all different sorts of classifications of face type, occlusion. That's how the teeth come together. Skeletal relationship of the occlusion. It's a huge list, and the good news is that we can see it earlier than we can, diabetes, for example.
I think for those people listening on the podcast, I think the thing that you're really trying to get across is that sleep apnea, which seems like if anybody has ever known somebody who has sleep apnea in the traditional sense, it looks and it sounds like very often aggressive, right? Mm-hmm. They have a hard time breathing.
Right.
It looks like a very over the top thing.
Right.
Whatever age they are that they have it. And you're really talking about a milder form of sleep apnea that is often undiagnosed, underdiagnosed, that's still there. And many people themselves don't even know that they have it, but they have it, and they have all these different things, including some of the things that you had mentioned on this list.
Right.
And before we talk about those things in detail, let's just come back to sleep apnea a little further. When people have sleep apnea, even if it's not super severe, but it's prominent, what kind of long-term impact does that have on our health?
Right. What you said previous to that was very interesting. There is a threshold for noticing sleep apnea, and that threshold is very low in dentistry. We're able to catch it sooner, and that's a very important point. This disease starts very early, and it's very insidious in that way. So what is sleep apnea? It's very gray. There's no point or threshold where all of a sudden you have sleep apnea. It can start from the time that you're born. It is the lack of the ability to breathe properly at night to the point where your sleep is interrupted. And in a nutshell, when we go into deep sleep, our muscles are paralyzed. When we reach that REM and stage 3, stage 4 sleep, there's some exceptions in REM, of course, but the muscles of the airway become flaccid. I mean, they lose their tone. And if you have an airway that is small to begin with, chances are that the sides, the walls of the airway will touch and fall together. And of course, that's going to be a area of resistance for air coming through and exiting. And of course, that's where the snoring comes from. It's a flapping of that tissue. And the more you snore, the more inflamed that tissue becomes. There's edema of the airway muscles. The airway muscles in women, they have protective hormones in women. Estrogen and progesterone protect them. That's why they catch up with men after menopause, even perimenopause, because they're low on those hormones. I mean, it is a lack of thriving at night, and it is something that it's curious because how did we get here? Obviously, we look back at our ancestors and we can see from their skeletons and their skulls that they had different airways than we did, and they didn't have these issues. And there are a lot of reasons for it, but I pretty much think it's very practical from my standpoint in my practice to assume that everyone has a sleep disorder breathing. And
it's getting worse. There's this rising epidemic of sleep apnea and all the different permutations of how it's impacting people, which we're going to talk about a little bit. But let's just chat about what you were sharing for a second, which is, why are we heading in this direction where more people who don't know that they have apnea are getting apnea? You hinted at a couple of components. Our jaw structure is different. So why is our jaw structure different now compared to our ancestors?
Right. It is different. We know it's different. We have the archaeological record of that. And the question is how did we get here? There are many theories. They're very solid theories. It's lack of breastfeeding. It's lack of chewing. It's eating processed foods at the right age when we should be eating something with more texture. It's the increased incidence of tongue ties that could actually be from us pushing too much B12 before prenatal, before conception. there's a better version of B12 to be taking. Those are the midline defects. What else? Breastfeeding.
But just taking
difficult.
one of those,
Yep.
Even the processed food alone, even when people eat a very healthy diet, one of the things you were sharing last night at dinner is that the food already is kind of coming pre-digested for them. It's blended as a smoothie. It's chopped up in a salad.
Right.
And we're no longer just sort of taking things and having to use our teeth for what they were designed to do.
That's right.
And when we're not chewing at that level, our formation in our muscles and our bones in our face just develop completely differently.
Yeah. It's actually the muscles of chewing and swallowing and the oral posture of where we hold our tongue that shapes our lower face. If the tongue isn't pushing out and up, if we're not chewing properly, if we're not using these muscles, our faces will be different. So whatever allows us to use more of those muscles in the right way will lead to better facial development. That's clear.
And on the extreme end, we know that sleep apnea long-term, people exposed to it, they're at a much higher risk of Alzheimer's. Can you talk about that?
Yeah, so sleep is not the only thing in dentistry that can lead to Alzheimer's, and that's exciting for dentistry now. But sleep is probably the biggest, good sleep, deep sleep, is probably the biggest fixer of our brains, the daily damage that we do to our brains. I mean, the brains use a lot of energy. We need a lot of cleansing and detoxifying of the brain at night. And that only really happens, the lymphatic system, the glial lymphatic system, these are something that was recently discovered in the brain. And it was first discussed in a TEDx talk, I remember that, where the speaker was talking about the brain shrinking, and that a famous Greek scientist or philosopher had actually discovered that and had mentioned it. And I thought that was fascinating, but it's confirmed. I mean, the brain at night has a chance, as does the liver, has an opportunity to fix itself and clean itself and take away the waste. And all our organs, all of our metabolic processes create waste. And the question is how do we clean that out? The liver does its job. It does it constantly during the day. But the brain only has a chance to do that at night. If you're not getting deep sleep and you're continually being interrupted due to a small airway or a collapsing airway, then that brain is starting off not fresh in the morning, and that damage, that lack of waste reduction is accumulating.
And we said long-term that can increase your likelihood of Alzheimer's.
Yes.
And in the short term, it could be you just wake up feeling not rested, you feel tired, you feel sluggish.
Yep.
There are instances, this is one I'd love to touch on. There's a whole sort of group of, can you talk about like women and sort of like the nervous system and the connection there of like sleep apnea and the nervous system for a lot of young women especially?
Well, I mean, there's that one study in Sweden, I think it was 2004, where they randomly selected from over 100,000 women, just women across the board, from 20 to 70 years old. And 50% of them had some form of sleep disorder breathing. Now, of course, if you're overweight and you're older, obese, high BMI, maybe it runs in the family, you would certainly see it there. But to see it in a 20-year-old woman or a 25-year-old woman who's fit and thin and healthy, that was a real wake-up call. For women, and I don't want to pick on women, of course, it happens to men as well, but a lot of the mood disorders and actually TMJ disorders tend to be more prevalent in women, and a lot of that has to do with sleep. How do I bring in TMJ to neurological and mood disorders? It's because they're all related to the grinding, the clenching, which is trying to keep the airway open. It is a factor in or a sign that that person is struggling to sleep at night. So if you're not fixing your brain at night and if you're grinding at night to keep your airway open, you're gonna suffer from depression, perhaps, mood disorders, and TMJ. They seem to be paired together.
And you're also not processing oxygen correctly inside the body. Can you talk about the relationship between like oxygen, breathing? I think we'll jump into a couple of these topics
There's
here.
There's a lot to discuss there.
And nitrous oxide and breathing through your nose versus your mouth. Give us an overview on that.
Right. Wow. It's very exciting. So when my daughter and I wrote the book, we did some research and And in my clinical practice, I noticed that people that can't breathe through their nose, first of all, let me back up. Dentists are great at knowing who mouth breathes and who nose breathes.
Tell us why.
Because when we lay the patient down and start throwing water in their mouth and putting our fingers in their mouth, they can't breathe. They're the ones who get up and spit a lot at the cuspidor. They're the ones that gag a lot. They have to put their hand up. The ones that can breathe through the nose, they can tolerate having that little pool of water in the back of their throat.
Right.
And they can breathe past it. So it's very obvious I mean, I always joke with patients, dentists probably invented waterboarding, right? I mean, it's why people don't want to come see us. It is a panic moment. It is a fight or flight response when your airway's blocked and you can't breathe through your nose. I mean, it's a lot like how we sleep at night. If we're not breathing at night, we're going to wake up a little anxious in the morning because we've been fighting for our life at night. If you have 12 interruptions like I did at night before I treated my sleep apnea per hour, that's 12 grizzly bear sightings at night. I mean, that will wear out your adrenal glands.
Your body doesn't know the difference. I just want to touch on that for a second and interrupt your story if that's okay. Is literally at night when you have a version of sleep apnea and there's a spectrum of how severe it is, your body actually feels that it's at risk of dying.
Yes.
And it can increase like cortisol in the body. It can have a shot of like adrenaline inside the body that basically says like, something's attacking me. I can't sleep properly.
Right.
And there's like, often if you know somebody that has severe sleep apnea who hasn't been treated, you'll see these major gasps for air in the middle of their night. I had a cousin who I recommended go for a sleep study, and he came back, and in the course of an hour, he was stopping to breathe 45 times on average in an hour. So 45 times in an hour.
And sometimes that's 50, 60 seconds. And some people can't even hold their breath that long. And then, the body will wake you up. It's fear of thriving. I mean, it's a guttural gut instinct of I'm going to die. And does that come through, if you've been sleeping? Absolutely. That's where a lot of the anxiety comes from. It's not just from the hormonal problems in the brain not being able to fix itself at night. It's from the anxiety. It's from feeling that way at night. And it can really, I think the enjoyment I get in doing what I do is that we can turn that around in a matter of 6 months. We see people and we take a little interview with them. We write down some notes on how they feel in the morning. And then 6 months after we've treated them, we interview them again. And it's remarkable to see the difference. I feel a little happier. I can't close my eyes after I wake up. I feel like getting out of bed. I feel a little bit better about the day. But if you're fighting for your life at night, you don't have time. Yeah, I mean, the glass is half empty. I mean, you're having a tough time. You're challenged the minute you wake up, and that's the exact time of day when you should feel rested, restored, and ready for, life in general.
Yeah, and I couldn't think of anything more to put that attention on with sleep. It's like, even if you don't have the perfect diet, like really to put attention in your sleep. Right. First of all, there is no perfect diet, and we don't believe in that, of course. But I'm just saying, I'd rather have somebody just have incredible sleep than not have their diet 100% tuned in, because that's how fundamentally important sleep is. So going back to your story, because I interrupted you, you were talking about, dentists are often the first to know about that, about whether or not somebody's good. And you were explaining the mechanism of how oxygen is processed inside the body and what happens exactly when we're breathing through the mouth versus doing what we were designed to do, which is breathing through the nose. So could you continue down that path?
So it's very interesting. And I didn't know this until about 5 years ago. And it started with the simple act of mouth taping. People that, for example, if I make an oral appliance, which is something that just keeps the chin from falling back when they go to sleep, that keeps the tongue and the airway open. There's CPAP therapy, APAP therapy. That's the little machine that people put on. These are the main solutions for sleep apnea. It keeps positive pressure in the airway and keeps it from collapsing. Those things work well if the patient is able to breathe through their nose. So that's how I first ran into this. I would make an oral appliance for someone and the results were not quite what I expected. And then I learned, of course, that, well, if they can't breathe through their nose, it's not going to work as well. Same thing for a CPAP. So that's how I kind of came across it. Then I did a lot of research, started reading up on it, read these pulmonology books, spoke to a lot of pulmonologists about it, and a lot of ear, nose, and throat MDs, and understood that things like, for example, when you breathe through your mouth only, you're not able to deal with your O2, your CO2 O2 mix in your blood. There's O2. CO2 is a waste product. It's coming out. O2 is what we're breathing in, and we want to get O2, oxygen, to our bloodstream. But if there's too much CO2, or if you are in acidosis, I mean, the analogy I use for patients, if you add carbonic acid to water to make it all bubbly, the pH drops. It becomes very acidic. And we talk about it a lot in dentistry because that's a drink that can dissolve enamel in your mouth. So it's the same thing with blood. Too much CO2 acidifies the blood, and that actually harms or prevents as much oxygen going from the lungs to the blood. So that's a big deal. Breathing through your nose is a better regulator of CO2. In other words, if you breathe through your nose most of the time, your CO2 levels will be optimal. The important thing in that, I didn't realize this until 5 years ago, and it really made me think, the body is controlling your breathing. It's the brainstem that is regulating the subconscious breathing. That part of the brainstem is looking at CO2 in the blood, not O2. So it's not responding to how much oxygen you have, which you would think that would be the process. It's responding to how much CO2 is in your blood. So that's where we get this panting and short breathing, which makes it worse, and we get dizzy. These are all the short-term effects of hyperventilation and all that. I mean, the old yogis were right. I mean, breathing is so important, and we somehow have forgotten to breathe. Maybe it's related to our airways. If you can't breathe through your nose, of course, and you have a lot of allergies due to your environment, I mean, that will turn you into a person who can only mouth breathe. And then it's difficult to breathe. So the pH of your blood, as it is anywhere in the body, is key to keeping your blood pressure low, regulating heart rate through breathing, and also just a general feeling of happiness and wellness.
And a lot of top athletes, I mean, like when I first heard about mouth taping in the context of, and we're going to talk about what that is, but when I first heard about mouth taping in the context of helping out with sleep apnea, or people that were having troubles or certain symptoms come up from not sleeping properly, I thought of sort of the history of a lot of elite athletes. When they work out, they would often have, some of them would have trainers who would say, oh yeah, I tell them to like tape their mouth when they train, because that teaches them to breathe. They couldn't explain the science of it all, but they should know they just got better performance, longer endurance from these athletes that were there. So there was a whole history of mouth taping and sort of elite athletes and performance.
It's the same thing in mountaineering, and this has been around before we know how it works, but when you're climbing at high altitude, you're lacking oxygen. So if you do what's called pressure breathing and rest step, it's a combination of resting your limbs. So you would pause between each step, lock your leg, but the breathing in between is very important. It's designed to help oxygenate it's really venting CO2. It's a pursing of the lips, breathing in air through your nose, pushing it out. But that process alone, if your partial pressures are lower, like at 10, 15, 20,000 feet, you're able to push more oxygen to your blood, which is going to your muscles, and which is what you need.
So let's just visualize it for those that are listening. When you're talking about people mouth breathing, so imagine you're sleeping at night, you're literally talking somebody who has their mouth open and is just breathing through there. So now let's talk about the sort of solution side of it, which is you are somebody who is a big encourager of mouth taping. So tell us exactly, what is mouth taping?
Sounds pretty crazy, doesn't it? Yeah. It is, I present it differently now. I would just tell patients, listen, you got a mouth tape for these reasons. And half of them will take that advice. And the ones that do are typically very pleased, but the other half just won't do it. I use it in my practice as a diagnostic tool, firstly. I want to know if the patient can nose breathe.
Can you actually breathe through your nose, or is it clogged? Or...
Does the tape stay on? They text me back in a few days, and if the tape stays on all night long and they're peeling it off in the morning, then I know what I'm dealing with when it comes to treating for sleep apnea and other things. So, but in general, the concept of mouth taping, it's a reminder. It's not creating this impermeable seal that could frighten people and maybe they would stop breathing at night. It's not about that. It's a reminder. It is a gentle reminder to keep your lips closed. And there are a lot of people out there that can do that on their own. And that's the way it was meant to be. When we go to sleep and we're relaxed, all the air coming through our nose and out of our nose should be enough. And there are a lot of advantages of doing that. Breathing through your mouth, though, a lot of us cannot do that, but a lot of us, because we mouth tape, are better at it. And what I tell people is that you may not be good at it at first.
Breathing through your nose.
Right, breathing through your nose and mouth taping, but push through it, work on it, and at some point, because you start using your nose again, there are a lot of borderline cases. I would say most of us are borderline. Then you're pushing warm air past the nasal sinuses again, the mucosa there. You're building a biome, a nasal biome. You are creating less edema. You're going to get less of a histaminic response when you come across an allergen like pollen, but it takes time. But if we stop using our nose to breathe, well, we're not getting the nitric oxide, we're not production, we're not getting filtration, humidification of the air. There's a temperature gradient between breathing air in through the nose as opposed to the mouth for the lungs. And I would think that we would want to keep that, at a healthy level, right? I mean, you don't want to, and also we dehydrate more often. We can lose up to a liter of water by mouth breathing. So if you're feeling dehydrated, I would look at if your mouth is open a lot. Now, of course, I'm not talking about talking and eating and all that, but at nighttime, the mouth should be closed. And the tape is a great reminder.
And you're not talking about packing tape or anything like that. There's actually specific mouth tape.
No duct tape. Yes.
No duct tape.
Right.
So people who get scared when they first heard the idea, like, oh my gosh, like, am I going to die in my sleep?
Right. Yes.
It's not anything like that.
Right.
It's strong enough to maintain a closure in the mouth, but it's weak enough that if you forced it, you could just force it off very easily, even if you were sleeping.
It would come off so easily. With just an opening of the mouth, it would come off.
So fundamentally, first and foremost, and I think this is just an important thing to say again, is that it's a tool to see, can you breathe the way that we were evolutionarily designed to breathe?
Yes.
And if you can't, now let's dig in a little bit deeper. I had a dear friend of mine who was waking up in the morning with just severe heart palpitations. She would wake up in the morning, she had severe heart palpitations, there was all this anxiety. She would text me in the morning sometimes and say, like, I just feel super anxious, everything like that. And it's right around that time, my dear friend Stephen Lynn sent me a bunch of resources, including some of your resources and other stuff, and said, great, because we just happened to be talking. He's a past guest on the podcast, and he said, you should just really, I overheard you talking about that. We were at a conference together. You should really look into this area. Like, does she breathe at night with her mouth open? I know this sounds crazy because she eats healthy, she's fit, everything like that. But this severe anxiety could be that when oxygen is not properly regulated at night and she's breathing through her mouth, it basically never lets her nervous system feel like she's fully at rest.
Right.
So she's in fight or flight the whole night, wakes up, and immediately feels this sort of extreme anxiety. Have you heard that example from patients in the past?
I have many patients that are that way. And they do wake up in a panic and their blood pressure is elevated, not just from the fight or flight, but from the acidosis from in the bloodstream, from mouth breathing means you're going to snore more often. I mean, you're pulling in a lot more air past the small airway. If it comes through the nose, it's baffled, it slows down, it's warmed. And as it gets pulled past the airway, less of it's coming through at that one time, and that's less likely to pull it closed. That's the Bernoulli principle, essentially. So there, yes, absolutely. It's in kids is even more phenomenal. ADD, ADHD, cavity rates that are just sky high. And they're the ones that are developing and growing. So breathing through your mouth while your face is developing, that's a big deal because that is what you're set with for life in terms of your facial type. If you don't grow properly here for up to age 10, the box, I call it the box, the nasal box, the airway box, those all tend to be squashed and made to be much smaller. So, and remember, kids don't develop their sinuses until age 4. Can you imagine being mouth breathing all those years and then the sinus comes online? Well, it's not going to feel needed. So why develop to its full potential? Because the kid is breathing through their mouths.
It's almost like them being in like a wheelchair, not using their legs, and their legs develop some level of atrophy and they don't end up being used. Yes. And that's happening from a breathing standpoint.
Right.
And if that continues the rest of their life, that can lead to all sorts of challenges, as we were sharing earlier. Yes. Speaking of kids, we have a mutual friend, Mike Mutzel, who was a past guest on this podcast,
Great guy,
who talked about keto and other things like that. And recently he shared how, you've been a big inspiration by him deciding to mouth tape their daughter.
Yes.
And he's been pretty open about that on social media and everything like that. So I don't think we're sharing any information that he wouldn't want to be shared. But, when a parent is thinking about how to support the muscle of breathing for their child, what are some of the signs that they should be looking for? Is it as simple as, hey, is my, go into my kid's room at night? Are they breathing through their mouth or are they breathing through their nose?
Right. That's exactly it. That's the first thing I'll say. You have to kind of sneak into your kid's room when they're asleep and find out whether that mouth is open or closed. Most parents know. It's one of the first things I ask, even before I see the child or the oral cavity. There are all sorts of signs that the child is mouth breathing, other than the fact of seeing their mouth open all the time. You can watch them while they're watching TV or studying. That certainly is doable. Boogers, lots of snot coming out of the nose. If they can't breathe through their nose, if they have allergies all the time, that's a dead giveaway. Posture is a big thing. The difference between nasal breathing and mouth breathing has an effect on all these cervical bones, and pulling in air, for example, past the nose. The pituitary gland, the hypothalamus is there. Those organs can probably see light. That would affect the circadian rhythm of the child. Is the child spinning in bed? It's a lot of it's related to sleep apnea. Are they snoring? It's this one big multifactorial package that you have to look at, and mouth breathing is part of it. But the number one way to do that is exactly what you said. You got to sneak in and sit there. So I recommend that parents take their Kindle in there, not their phone, because that's blue light, may wake up the kid, and just sit there for 15, 20 minutes. If there's a chair in the room, that's great. If you're leaning up against the back of the bed, you can hear it. You don't even have to see it. And I would do that often. Now, obviously, if they have a cold, that's a different story. But when they're not sick and they don't have a cold, make sure your child is breathing through their nose at all opportune moments. That would not be during exercise, not if they had a cold, and eating and talking, and that would be it. Mouth breathing is an emergency state. We mouth breathe because we just need to bring in more air. Our normal state is breathing, exhaling, and inhaling through the nose.
And when it comes to actually getting mouth tape, and let's say with kids, keeping down that storyline, and we want to implement it and start using with them, just walk us through that. What type of, are all mouth tapes equal? Do people just go on Amazon?
Yeah, exactly.
When they get it, so how do they begin? And do you have any tips on sort of explaining it to kids?
Right. I don't hesitate telling parents to mouth tape, but most parents will hesitate mouth taping their children. There's something called vertical taping, where you can just tape in a vertical mode. That way, the sides of the mouth are open. There's a special tape that I recommend, which I'll mention. But I do have a lot of patients that tape between the ages of like 1.5 to age 8 or 9. And the story I like to tell is this one kid who started at age 2, and he had these nightmares. And the mother, maybe about 2 years later, a year and a half later, the mother said, Johnny, his name is not Johnny, tell him what you told me. And he turned to me and he told me the story. It was not just a comment, it was a long story about his dreams were getting better. And he loves mouth taping, and he gets upset when his mom doesn't have it for him. And so I hear a lot of stories like that, from improvement of dreams. I'm not sure how that works, but fewer cavities is a big one. I have a lot of kids that have a high rate of decay. We've identified that they are mouth breathing, and we tell the parents, listen, you can spend $2,000 to $3,000 to $4,000 fixing just baby teeth, deciduous teeth, which I hesitate to do because that's a traumatic experience for a child. Typically, it's stressful. Or you can just, let's stop this right now. And so there's some diet management counseling going on, but mouth taping is the big one. That is a big factor in decay. I've seen it firsthand.
And what's the relationship between cavities and breathing?
Or breathing through your mouth. So, the mouth has this incredible biome, just like the gut, right?
Yeah, the
bunch of bacteria.
Microbiome.
Exactly. It's finally come online. I'm very excited to read about it now, and it's basically just the headwaters, or the first stop on this long train line with many stations and of bacteria. And the mouth, of course, is a little different than the gut, but there's this sensitive population of bacteria in the mouth, and one of the things that will turn it into a dysbiotic kind of environment, which you've heard that term before with the gut, it can happen in the mouth, There are many ways of doing that. One of the major ways is by, just as in the gut, is by changing the pH. When you mouth breathe and your mouth becomes dry and the saliva is not present, the pH drops. That is easily measured. We've known this for a long time. But what it does in the mouth is it allows the decay rate to increase for a variety of reasons. It's lack of saliva and the buffering of the saliva, but the saliva has phosphorus in it and calcium and hydroxyapatite. It has all these ingredients that are required to keep the tooth remineralizing faster than it's demineralizing. Teeth are like bones. They just have a shiny outer shell, but they are dynamic. They're always changing. And a few weeks of very dry mouth, that equilibrium will switch over to the demineralization side, and then you'll start seeing the decays, the decay and the carious lesions forming on the teeth. And no dentist and no parent should ever underestimate what that's going to cost you in terms of just talking about cavities, not about airway development or facial development, just that alone.
It's great to expand on that story because the traditional story that we all grew up is all cavities is sugar.
Mm-hmm.
And I can remember even a few friends of mine that are parents are like, listen, my kid doesn't eat any sugar
Mm-hmm.
at all. And they still
Mm-hmm.
have these cavities and being perplexed and where is
Right.
it coming from?
Mm-hmm.
And so it's great to include this component to see, is it part of the piece of the puzzle
Mm-hmm.
that's going on?
Yeah, and diet is definitely number two. But I have a lot of patients that have a really good diet. Parents in my area of where I practice, they're doing paleo and all that, but they still have decay. And that's because they're breathing through their mouth. Their mouth is bone dry from maybe midnight, 1 o'clock on.
Could also be some missing key nutrients, which we'll talk about
Yep.
in a little bit.
Mm-hmm.
Let's continue down that path. So let's say now you've taped the mouth of either yourself, your spouse.
Right. I wouldn't recommend that, by the way. Don't ever tape your partner's mouth. It's you should tape your own mouth.
Yeah,
right.
you should tape your own mouth.
Right.
If they get excited, they want to try it,
Yep.
they can do it on their own.
Absolutely.
But you can let them, do you ever suggest that couples, notice or check in on each other if they're breathing through their
Yes,
mouth at
absolutely.
night? And usually they already know.
Yeah, sleep partner reports are very important. The problem is with married couples, you'll get a lot of disagreement. Like, I don't snore, but you snore, and it goes back and forth. So I take that with a very
work on yourself first.
Exactly right.
And then let other people do whatever they want to do.
That's where we start mentioning the phone apps and sleeping alone in a room for a few nights and getting some good data. Right.
So you've taped your mouth. Now, is that it? Is mouth taping now the end all be all of building back that muscle up?
Mm-hmm.
Or do sometimes people have to look at deeper root issues that are going on that are chronically keeping them from breathing through their...
It's a really good question because, that's not it. That's not the end of it. For some people, it can be. But for example, if you have a tongue tie, if you...
So let's just start right there because a lot of people, especially if they're not parents, I don't think they even know what a tongue tie is. So explain what a tongue tie is.
Right. Well, it turns out our little granddaughter of 18 months now had a tongue tie, and the hospital snipped it. They do a little quick procedure. It takes all of 30 seconds. And a tongue tie literally is it's a midline defect. It's tissue that is along the midline, and it was supposed to, in utero, fall away. It was supposed to necrose away. So it's redundant tissue, and the tissue is underneath the tongue, and it's like a little, it's like a string or like a rope that very thin of cartilage and frenum, and it's pulling the tongue down. It pulls the tongue down in a certain position. It can pull it from the back, it can pull it down, or it can prevent you from sticking it out and moving it around. Essentially, if it is held in place, there are positions of the tongue, it's called oral posture now, that we need to see in deep sleep. Because if we can't let the tongue move forward and spread out and push upwards, then the airway could be blocked because then it's going to go in that direction. So that little tie down is very, very important. And
there's more awareness of it now, but there's a whole group of generation of people that if there wasn't that awareness in the past as much as there is now, I would say.
Yes, that's true.
So there's a lot of people that are adults that are walking around with a very strong tongue tie.
Yes, I know a lot of them. And the question to them is, and they ask me, should I do it as an adult? And I would say yes for optimal sleeping. If they have a sleep issue, I will refer them out for a tongue tie surgery.
And it's a very simple operation.
It typically is. If it's a posterior tongue tie, it can be a little bit more difficult. It's done with lasers now. It's compared to sleep apnea surgeries, it is much easier. It is a 10 to 15, 20-minute procedure. It's outpatient. It's usually done with local anesthesia. So, and there's a healing period, but it's very doable.
Because there's traditionally in dentistry and in medicine, there was this focus on like, oh, does the patient have like a deviated septum? Is it this? Is it that? And there was all these very complicated, or if somebody's suffering with like a deep sinus issue. But some of that stuff can be influenced heavily by just how we breathe.
Yes.
And this is a lot simpler of an operation. Obviously, they have to see if somebody, they could literally go to the mirror or show somebody else. Probably it's a little hard to see your own.
Yes.
And
Actually,
they probably need somebody trained.
Yes. I mean, you can go on YouTube, you can go to image views, and you can see lots of great photos on tongue tie. And if you have good lighting, like a flashlight, and you look in the mirror, you won't be able to tell to what degree the tongue tie is, what state it's in, but you'll be able to know. But why not go see your dentist? He'll be able to diagnose it for you and refer you to the right people. So
the only question is if they're trained, he or she, in whether or not that's affecting their sleep.
Yes.
Component.
Yes.
They might say, well, you have a tongue tie, but if you're fine and you're there, it's no big deal.
Right. And that's not a good place to go, especially if you have a sleep disorder breathing issue.
So you need to find somebody who's trained in this and can dig in deeper.
Yes.
And we'll talk about resources and how to get there. So that's a tongue tie is one component.
Yep.
Sometimes it's how the jaw is shaped. And you mentioned earlier something called a dental device. Let's talk about what that is and when you typically would bring that in for a patient.
So that's for someone like myself that has a class 2 classification. That's a slightly retruded chin. And where the chin and tongue go, that's where it goes back onto the airway. And people that have developed that way, whether it's through lack of breastfeeding or mouth breathing as a kid, it could also just be crazy orthodontics, improperly done orthodontics. I mean, there are many ways to get there, but it doesn't matter because if that happens, I mean, the jawbone itself and the tongue are quite heavy. And when you lie back and recline and the muscles disengage from holding that in place, that's a lot of tissue that can sit on the back of the airway, the nasopharynx.
It's literally pushing up and closing off.
Exactly. Or it's getting very close to it where when that muscle, the back of the nasopharynx, the posterior region of it starts collapsing and the tongue is loose. And if you have a dry mouth, all those tissues back there become very dry too. And when they're dry, they tend to stick together. If they're moist, they pull away from each other more likely. So that's another kind of concern with dry mouth. But I mean, that is a simple way of doing it. It doesn't work on everyone, but if you can, and there's a way to preview this. It's called the Mueller's maneuver. While looking at what mandibular advancement does, it's a little nasal endoscopy unit that goes into the nose. I've actually worked with an ENT that I kind of had to tell him what to do, and he was glad to do it. And I sent him some research and some studies on it, but it was not in his typical specialty training. And he's one of the few guys that can do it. And he can literally from the top see the opening of the nasopharynx. And there's the velopharynx, and the pharynx will narrow as it goes down to the esophagus and all that. But if that opening is wide, and if you do this to the jaw, let it collapse.
For those that are listening, you're pushing your jaw back.
Exactly right. Then if they see the tongue push back into that space, and that patient may be a very good candidate for an oral appliance because the oral appliance simply prevents that from happening. So as you lie down, not only does it prevent it from falling back up against the back of the throat, but it actually progressively over time, we adjust it so we can actually push the jaw out. Now, if you have a tongue tie, if you can't breathe through your nose, I mean, these are all factors in the same that are factored into the equation. But if all that is good, then these devices can help.
And for anybody who's listening, who's like mouth taping and dental devices and all these things, I mean, when did life get so complicated? And it's really, if we just zoom out and remind everyone, we are sort of making up for the fact that our facial structure has changed because our diet, our lifestyle, how we are brought up has changed more in the last, 200, 300 years.
Cesarean
sections, and all the different chemicals and foods that we eat that change the oral microbiome. And that has left us in a place where we are not really how we were originally designed. So even though our body is fundamentally built on the fact that we were designed to breathe through our nose as one component, we're sort of trying to figure out how to just get our body to do what it was doing naturally. So that's where all these tools and devices come in,
Right.
because the flip side is, if you have severe issues with your sleep, anybody who's listened to this podcast knows we're a huge fan of sleep. We did an entire show with Sean Stevenson just a couple
Great.
episodes
That's
ago.
great.
When you don't have proper sleep, it increases your risk of obesity and so many other challenges that are there. We talked about Alzheimer's. And so if you're somebody who thinks that your sleep is being affected, or you have these other symptoms that are associated with poor sleep, this is the time to take this topic quite seriously, because it could be the answer when you're searching out there for the right supplement or this change or this other thing. It could be as fundamental as fixing sleep.
And that's why I argue that everyone should get a sleep study, at age 5, sooner if you are showing symptoms, at age 10. We need a quick, easy alternative to measure our sleep. Even nightly would be nice. And I've worked with different companies on that. But the PSG, which is the gold standard, the polysomnography, that's where you go into a clinic, they wire you up, you sleep in someone else's bed, you have your own room. That's still the gold standard, but we need something besides that because it's not readily available. The insurance companies push back on it. Even primary care physicians push back on it. They're actually incentivized not to do too many diagnostic tests. And this is a good one to push back on. If your patient's thin and healthy and it's not complaining of being tired or tiredness or napping, and then that person doesn't need the sleep study.
You have a practice up in the Bay, and you have a lot of patients who you've worked with to sort of help them navigate that. So for those listening who are like, you know what, I really do need a sleep study, any pointers you can give to them to navigating the medical system, especially if they're not a typical candidate who would be typical candidate for sleep apnea, overweight, older male.
Right.
What are some key things that they can bring in besides asking nicely to their doctor to get a sleep study to happen?
And asking nicely, your physician doesn't always work. So let me tell you my story quickly. I was very healthy, very fit. I mean, I would summit 14, 15,000 foot peaks. I would ski down them. I would mountain bike for 6 hours straight. I still do some of that. And so I felt very, very fit. And then one day we dropped my oldest off to college. We were all in the same room. It had been a while in the hotel room, of course. And my daughters woke me up the next morning and said, "Dad, you were just like a freight train. What's going on?" And that was
They couldn't wake you up.
Right. Well, they could wake me up, but I was tired and I was snoring, and they couldn't sleep. So it turns out it was actually my wife who was doing most of the snoring. So we both realized at that point in time, and we're both medical professionals, who would have thought, right, that there was a problem. And the next morning we're having, our free continental breakfast, and which wasn't much choice there, and this older man, he had overheard us talking about it, and he pulled us aside, this older gentleman, no medical background at all. And he said, "Listen, you got to get a CPAP. You got to get on this right away." And I have to hand it to that guy, because we did do that, and we did it, but we then discovered how difficult it was. And again, we're seasoned professionals. My wife's an RN. She's in biotech, biomed. I'm a dentist. We have good physicians. It became a very difficult process. We felt like we weren't getting the information that we needed to make the right decisions. And the web was there, of course, but there really wasn't a very organized, clean, concise way of dealing with this. And remember, these people, like my wife and I, we're tired. These patients are tired. They don't know where to go. And the advice that they were getting was from each singular, specialty. The primary care physician would say, "You're probably fine. Maybe you're depressed. Maybe you should take a psychotropic drug. Pull down the blinds. Make sure your room is dark. That kind of stuff." And then, if you went to your ENT, I refer a lot to ENTs. A lot of them will say, "Well, listen, the adenoids and the tonsils, leave them in. They'll get better over time." But the patient can't breathe past them. It's narrowing the airway. So there's a lot of pushback. I talked earlier about the cost of it. The insurance companies not liking it, and the incentivized medical doctors that are pushing back on diagnostics, the cost of diagnostics. So we navigated this whole system, and that's really the genesis of why I wrote that book. My daughter said, "Dad, you've learned a lot. Let's get that out to our readers," and she was absolutely right. So in that book, and in my TEDx talk, I just try and keep it very simple and concise. And I still, to this day, if they haven't read the book, I get people that are very confused. They're being given different information from different specialties, even from other dentists, and so it's a difficult system to navigate. I'm not saying it's that way on purpose. It's just there's so many factors in diagnosing and treating and then verifying sleep that it would be nice if there was a one-stop shop for that kind of thing. And reading the book will help. There's stuff on the internet about it. I would tell people, don't get discouraged, and maybe your dentist has a solution. Maybe they can steer you through it. And a lot of dentists now are being trained in this, and they can simplify this. Dentists are not allowed to diagnose sleep apnea. That is in the realm of medicine, and that's fine. Our part of it is early screening for it, and we're happy to do that, and we're good at it. But when it comes to treatment, we do our oral appliances. That's after a prescription's been written by the physician, and that's sometimes in conjunction with the CPAP, APAP. But I wouldn't hesitate to ask your dentist. Your dentist may have some answers for you. The thing that I talked about this before, is I'm looking for this not quick, but very accurate at-home study that costs very little money. Because when I titrate my device, my oral appliance, I need data from that. I need data from every night's sleep and where that best position is for the mandible. And I also need to know for my sleep and for my wife's sleep, I need to verify my ability to sleep properly. Because the devices are in place, but if you gain weight as you age, as you get older, if you're a woman, if you have menopause, when you get menopause, all these things will change your sleep. So this is something we need to be checking in at least, daily, nightly would be nice. And I don't want to sound too obsessive about that, but we have lots of devices that can do that. But at least yearly, I would definitely check in with your sleep and ask yourself the question, am I getting deep sleep?
And can individuals just pay out of pocket to go get a sleep study done?
They can, yes. Yeah. That's a great
thing. So if you are
thing.
getting a little bit of resistance out there, you can look up sleep center nearby you, and you can choose to just go down that route.
Right.
Do you know about how much they cost?
Well, I do. I set up a relationship for that. Interesting that you brought that up. For that reason, I work and live in a very affluent area, and there are a lot of people that don't even want to try to go through the system. They just want the sleep study right away, and that's fine. I have a conduit to a sleep lab that I can actually refer patients to, and the cash price is $1,000 as opposed to a PSG, which can be $2,500 to $4,500. Unless you want to have it at the Ritz-Carlton, which is available. I don't know what that costs, but that's expensive.
But ultimately, this is something that as we raise more awareness, because not everybody has those resources, not everybody is in a privileged position to be able to pay out of pocket to go do it. Just raising awareness is important. And have you even had patients take your book and suggest, if their dentist is open-minded,
Yes.
Read it a little bit?
Yes.
And kind of dig into it?
Yes. And that book's been given to a lot of dentists, and it's very gratifying to hear. But there's plenty of resources out there for dentists now, and they are the American Academy of Dental Sleep Medicine is my favorite, and that's where I learned most of what I know about sleep apnea. And that's a fantastic resource. And
if somebody's looking for a dentist that can help them with this, can they go on their website? Do they have like a database? Exactly.
They have a database by zip code and a radius, and it works quite well. Yeah.
So, I always love stories. Is there a patient of yours who you think about when they started implementing these things and really focusing on it, just the cascading effects? Is there anybody that comes to mind, a story, a testimonial that you wouldn't mind sharing with the listeners here of just what's possible when we really dial in our sleep by fixing these core things?
I have a lot of stories, and I don't want to sound redundant. I've said it before. I'll give you a few real quickly. One is the woman who had the strength to leave her husband. It was a domestic abuse issue because we helped her get her sleep in order. She had an AHI of 39 interruptions per hour. And it was about a period of 12 months where she came in and we were all in tears, but she finally announced to us that she was able to leave her husband. She had gained the courage to do it. She was too anxious and too afraid and wasn't feeling well. Another favorite story I have is this young man who came in as a new patient, jumped in the chair. I was marveling at his perfect bone structure and teeth, no crowding, room for the wisdom teeth, or future room for the wisdom teeth, great airway, no anxiety at all. After the exam, he ran over to his mother, jumped into her lap, pulled off her sweater and latched on. He was about 5 years old. He was still on the breast. He was a patient from a African country. And I had never seen anything like that. I didn't know that was going to happen. And then, of course, I made that correlation. It's like, well, of course. I mean, they weren't
and a lot
eating.
of these-
They had just emigrated, and they weren't eating a Western diet. I mean, Weston Price just talked about that in the 1900s, early 1900s.
So just unpack that one, because I think a lot of people who are not familiar with that, they don't know if you're saying that is that a good thing or is it a bad
it's a great
thing?
It's a great thing. I'm not sure it was a good thing for Mom, but she didn't seem to mind. But
but basically, in a lot of sort of other societies, kids might breastfeed for a lot longer, right? They might breastfeed for a lot longer, like 4 and 5 years old.
Because the minute they're off the breast, they're living in nutritional poverty.
Right.
Right.
And so
it's a great thing because
because he had breastfed longer, his bone structure was
incredible.
Perfect.
Yeah, I didn't even at first it was an anomaly to me. It's like, what is the tuberosity width, the width between the two upper second molars, and the horseshoe shape of the arch, and the room for the tongue. I mean, the tongue, when it rested, it just fell away. It was below the plane of occlusion. The teeth were pearly white. I mean, it was an amazing thing. It really threw me. This was many years ago.
But to talk about it a little further, it's not that you're advocating people breastfeed to that level. It's just not possible.
I would never say that to a woman. Absolutely not. No.
And it's not possible in modern society. And there's all sorts of like socio aspects, other things like that.
Well, it could have been his diet as well. It could have been the way he was. I mean, living in another country outside of the U.S. I mean, there are other factors.
There's other factors.
Yes, but
that seems.
But the breastfeeding is the one that made me think, wow, now I get it. It's a different kind of upbringing.
Right. It's a different upbringing.
That was the kind of a tipping point. Like that's I'm sure he was born vaginally. I mean, the old-fashioned way.
No fluoride in the water.
Right. No fluoride in the water. Right. Lots of biome everywhere.
Yeah.
It was a formative moment for me.
Let's touch on a couple of the topics here on just overall dental health, oral microbiome, because we focused on the sleep apnea and the sleep component and mouth taping and some of the root factors that cause it and the problems with it. But that's not the only thing out there when it comes to dental health and oral health. What are some other big things when you talk about dentists looking upstream and being able to see things that will come down the road 10, 20 years down the line? We talked about sleep apnea and how that could lead to a whole host of things. What are some other components that when you catch them early, you're like, if this isn't addressed, this could be a major issue for the patient down the road?
The big one is gum disease, periodontal disease. And
so let's talk about that. When you talk about gum disease, what's the definition of gum disease?
The mouth is unique in that it has these bony-like protrusions coming through this protective barrier. The mouth is very similar to the gut. It has a stratified layer. It's got a lot of mucus. It's a little thicker, but it is also permeable like the gut is. It essentially is the beginning of the gut. But since it opens and there's a lot of trauma of, like tortilla chips and sharp things and hard, crusty foods, and the mouth can dry. It needs a slightly tougher kind of nature to it. So it's pulling in a lot of air. We use it to speak and to smile, and it helps with mating, and it helps pick up biome as we travel through the vaginal, through our mother's birth canal. I mean, the mouth is very unique in that way. But its most unique aspect is through that barrier. Think of in your intestines, if you had a little tooth poking through, that would be very difficult to maintain from being permeable and from allowing bacteria from the outside to get inside. And in fact, it is a very vulnerable kind of barrier, or it is a barrier. So as the teeth come through this thick layer of mucosa, we need to prevent the bacteria in the mouth from getting inside the body. And it does a pretty good job until certain things happen. And that is essentially what gum disease is. It's a breakdown of that barrier. And the immune system in that area, it's very attentive, very proactive. It even becomes more so. And I would classify gum disease actually as an autoimmune disease. I really do believe that's where we're going with gum disease. And add that to all the other autoimmune diseases. These are the diseases that 6 or 7 of us out of 10 die of and live with. So again, if this disease is very invisible in the beginning, your gums don't necessarily bleed. There's no sign of it. There's no gum recession. Dentists measure pockets by depth in millimeters. And we start that at age 5 or 6, and we get good baseline readings. In those pockets, if they start getting deeper, the collagen is breaking down. The body is attacking itself. It is like cytokines. They're pro-inflammatory cytokines. They're released in response to an inflammatory insult, or actually an invasion of bacteria, and then the inflammation comes, and that's how it works with it. But there are some cytokines that actually attack parts of the body that we need, and that's that little collagen layer, those little fibers that keep that girdle of tissue around that protruding tooth and preventing that seal from breaking. And that seal is crucial to when it comes to Alzheimer's. That's the big news recently in a study out of San Francisco and Japan, that if those bacteria get through, they can enter the bloodstream and actually pass across the blood-brain barrier, but it can also enter your spinal fluid. So that now could be a causative agent in Alzheimer's. And that's something that 60, maybe 70% of us have in this country, is gingivitis or different stages of periodontitis. That is an endemic inflammatory disease that a lot of us, the majority of us, are getting. And if it contributes in that way to systemic diseases, it can contribute to diabetes, insulin resistance, and other things too as well, and sudden death. I mean, bacteremias, heart infections, heart muscle stuff. That's a pretty serious thing. So, and mouth breathing, of course, contributes to that. I had to throw that in because
mouth breathing can accelerate it.
It can accelerate it because the biome changes, because everything's dry, the pH has dropped, and that's just going to make things worse. I'm not sure which comes first. Again, it's multifactorial, but so gum disease is a big one, and I think it's very important. Take-home message for that is make sure you never get gum disease. It's very difficult to solve. We arrest it essentially.
It's tough to go backwards.
It's tough to go backwards. Yes, it is. And so prevention is key. And are there other factors that make us more likely to have gum disease? Did our ancestors have that prevalence of gum disease? There are no signs of that. So it is probably diet related. It could be environmentally related. It could be the chemicals and the inability to be able to breathe through our nose. And it could even be related to sleep apnea, because that sleep apnea can affect the immune system. But it is definitely tied to the oral microbiome and even the gut microbiome.
We talked about mouth taping, and we've talked a lot about diet and the importance of certain foods in the podcast before, and what that diet looks like and how to personalize it, and what inflammatory foods are that are out there. What are some, so those are two big pillars that can contribute to gum disease. Let's talk about like some other ones that are out there that not only can contribute to gum disease, but can have other challenges. So let's talk about water and the water that people drink from home.
Right.
And the other products, sort of environmental factors and products that we use.
Toothpaste, mouthwashes.
Toothpaste. So let's first start off with water.
Okay.
Most of the water in this country is treated, and then it goes through a whole system of pipes, some which have not been replaced in years.
Right.
So they can have lead contamination and other things, heavy metals.
Flint, Michigan is a perfect example.
And Erin Brockovich, who's a good friend of ours and been part of our Broken Brain docuseries, she says there's 300 to 400 flints that are happening around there. Yes. They just haven't been discovered.
If not more.
Yes. If not more.
Right.
Maybe not at that full severity, but are on their way over.
Right.
So water, let's start off with water and the way that it's treated and what you recommend to your patients.
Well, so when Catherine was born, my oldest, she's 30 now, so that was 31 years ago. One thing I wanted to do is get the fluoride out of my water. And the only thing at that time was distillation. Distilling your water. And so we bought a distiller. It was an expensive item, and all our kids were raised on distilled water. I didn't want my kids to ingest fluoride. I actually have type 1 fluorosis. I grew up in San Francisco. There was fluoridated water, and I have little white spots on my teeth, which is the first sign of fluorosis, too much fluoride in the teeth.
And just one question for you. When you were doing the distilled water, you were remineralizing it. And
yeah, I wasn't too worried about that. I mean, it's easy to remineralize, but if I didn't, I mean, you get minerals from other sources. I mean, if you eat a good diet, you're getting tons of minerals. You can also add trace elements and
minerals.
Yeah, exactly right. Yes.
So now there's a lot more. Do you recommend reverse osmosis?
Reverse osmosis seems to work well. Yes.
To get out fluoride and other heavy metals and other aspects.
Yeah. I still like distilling water because that's pretty pure. I mean, once it evaporates and reforms in the container, that's pure rainwater. That's pretty good. Got it.
And so that was one thing that you did on that. Let's touch touch on a different topic, and you recommend pretty much for all of your patients to have filtered water at home.
Yes. Oh, absolutely. It's a must.
And it's not bottled
in fact, I
water.
won't go to a friend's house and drink their tap water unless I know how they're filtering. We have friends that live on Lake Tahoe and they drink the water from the lake. It's untreated. We have a place up in Tahoe that gets spring water from a aquifer, and we see the reports. It's not chlorinated. I still will filter that water. I think you have to be very careful. I mean, with water. Water is very important. We drink a lot of it. There's a lot of water in us. We're made up of a lot of H2O, and it better be as clean as possible. And our water supply is very contaminated. I mean, don't listen to the government, and it's not a conspiracy, of course. It is the fact that they're overwhelmed. They have to add chlorine, and when you do things on large scales, there are some compromises. It's that simple.
And even if they're testing the water coming out of the treatment plant, they're not looking at all the implications. Like this building that we're in right now, that our office is in Santa Monica, it was built in 1911.
Right.
And we used to share an office space with a dear friend of ours next door before we moved into this bigger space. And he kept on saying, my stomach feels weird. Something's going on, that sort of stuff. Finally, one of our team members asked him, are you drinking the water here?
Right.
He's like, yeah, in the morning I went to fill up because we didn't have the water system installed yet.
Right.
And they were like, dude, this building is so old. You're probably getting all sorts of lead and other things like that. He stopped drinking the water from the building and his gut issues went away.
Yeah.
So now we have filtered water, and there's tons of great filters that are out there. The Berkey system, AquaTrue, which is a water filter we often recommend.
Zero water is good.
Zero
inexpensive,
water.
yes.
They're inexpensive.
Yes.
And they don't have to be a major thing.
Even bottled water. You have to be careful with bottled water.
Yeah, and the answer is not bottled water because there's microplastics now in it.
Oh, yeah.
There's xenoestrogens that are inside of it that can confuse the body.
Right.
And also,
and BPA free is ridiculous. It's on to the next.
BPA free is ridiculous. Yes. That's not the answer. Yeah, and it's bad for the environment.
Right. And also, there are things called overfeeds. I think that's the term, where a municipal water supply will add too much fluoride, and the warning goes out. But by the time the warning goes out, the kids have had too much fluoride, and that gets incorporated into all your calcified tissues, including your teeth.
So water is the first and fundamental step. Have clean water in your home.
Yes.
Let's go to products that people use.
Okay.
The first obvious one. Let's talk about toothpaste.
Yep.
Right. So people grew up. They thought fluoride is great, and there's even still the stance of the American Dental Association is that fluoride's cool.
Yes.
Right. Just talk briefly about fluoride.
Well, so many dentists would disagree with me, although there is a growing concern, and there are new studies on what it does to the brain health of your child if you ingest fluoride. There are two ways of getting fluoride: ingesting the fluoride through water ingestion, and that going into the bloodstream and going into teeth that are forming and bones that are forming. And then there's topical application of fluoride. And we have fluoride in toothpaste. It's not at a very strong level. I think it was mostly a marketing ploy that when the fluoride was added to the water, and fluoride was the big deal in the 60s, then the toothpaste company said, listen, we've got it in our toothpaste as well. One more reason to buy it. But I would be very wary of fluoride. I have been, as you just heard, for 30 plus years. And my kids don't have fluorosis, and they don't have any cavities. They had a good diet, not a perfect diet. And it's possible. The fluoride solution is a kind of a mass kind of approach to large communities that don't have access to a good diet or can't afford a good diet. I mean, that
regular dental care.
Or regular dental care, exactly. Or any three of those. And that's, to me, is not a good solution. That doesn't address root cause issues, and it misleads us. And over time, for me, back then, I have more data now, and I would recommend viewers going to the Fluoride Action Network. That is a great group of PhDs and physicians that are gathering all the data against and suing actually the government on fluoridation. And so far, everything's going very well. The lawsuit has jumped a few courts and is moving upstream. So the fluoride, I would be wary. And my argument 30 years ago was it was a lesser of two evils. If any one of those things that I had heard about that fluoride could do, like hip fractures and lowering the child's IQ and all that, if any of that was true, I would feel bad, because by taking out the fluoride, I was risking only a few cavities. And of course, I was a dentist, I could fix that, but I don't want my kids to have cavities. I wouldn't want any kid to have any cavities. But when you weigh those two things, I think risking a few cavities it's something you can sleep with at night.
And long-term exposure to fluoride is, can could have brain health implications. We just don't know right now.
We do know a lot. I mean, there are a lot of European water supplies that have not gone to fluoridation or have reversed their fluoridation. Same story with chlorine. Chlorinated water supplies, or the bromine that they add now. Ozonation seems to be big in Europe and in Australia as well. So not everyone's fluoridating the water, and the Americans are big on that. Some other countries are, but there are a lot of countries that are not. And I think the jury is out as to the efficacy of fluoride. And I think the jury on what it can do to you and the risks of too much fluoride or any fluoride ingestion is mounting.
You have a great page on Ask the Dentist. I shared it actually on my Instagram this morning because I always have friends asking me. People always love practical stuff. I know there's a couple companies that you're a fan of when it comes to toothpaste. Instead of going down the route of Colgate and fluoride and everything like that, what are some toothpastes that are out there that you do like?
Right. Well, I mean, it's our fault. Dentists have been promoting these carpet bombing type of toothpaste with emulsifiers and chemicals and pesticides and soaps and ingredients that have nothing to do with oral health, that have everything to do with making a big batch of toothpaste and marketing. Right, exactly. So there are plenty of toothpaste out there now. The choice back when I was a young man, it was very few, maybe 4 or 5 different types of toothpaste. Now you could probably pick from over 100. And that's wonderful. I love earth paste. I'm not a big fan of minty flavors, but they have a citrus flavor, Radius. I was using Radius toothpaste this morning. And toothpaste isn't that important. If you're eating a good diet, I mean, you can use very little of it and you can skip it sometimes. The brushing and the flossing are probably the most important things. If you have a diet that stains your teeth, you may have to use the toothpaste that's slightly more abrasive. And those alternatives I just mentioned have versions of whitening. Jason's makes a good product. Dr. Bronner's makes a good product. These are all very natural toothpaste, but they're probably being made in smaller batches, and that's how they're able to make it with safer ingredients. So there are lots of alternatives out there now.
Mouthwash.
Nothing to say. Don't like it. Even a bad mouthwash is terrible. Even a good mouthwash is a waste of time. It just doesn't do anything. It's not active enough. It's like you could rinse with salt water and it would have the same effect, or baking soda, right? Yeah.
And would be better for you and would preserve the oral microbiome.
Exactly.
But let's look at the reason that people often use mouthwash, which we were talking about last night. People have issues with bad breath.
Yes.
What's the root issues of bad breath?
It's a dysbiosis. Clearly it's a dysbiosis, and it could be GI issues as well, but it's not, mouthwash can be very harmful. It is more harmful than it does any good.
And it's not addressing the root issue.
Exactly. It's not addressing the root issue, and it's actually masking everything that is wrong in your mouth, and it masks it for 10, 15 minutes. And I have patients that I know of that used to, I think I've gotten to them by now, they used to rinse with Listerine on top of the hour at work. It was a, or Scope. They used to go in the bathroom, and one guy even had a little, little whiskey flask. And it wasn't whiskey. It was, and he wasn't swallowing it. He wasn't alcoholic. He was swishing that every hour on top of the hour at work. He felt that was the best way to get along with his coworkers, and that is the biggest Band-Aid ever. I mean, mouthwash is a waste of time.
Yeah.
Don't invest in it. It's better not to use anything, and work on brushing and flossing and eating well, and working on your oral microbiome.
And to look maybe deeper at some gut dysbiosis, mouth bad breath could be a sign that there's candida, could be all sorts of other gut issues.
Yes.
Think about maybe doing a gut protocol or working with a functional medicine doctor and really getting into your gut health if there's some severe issues with bad breath.
Point. Absolutely.
I want to go back to your book and sleep.
Yep.
And thank you for touching on those. Those are always topics that people ask about.
People always ask, what should I be using?
Yeah, what should we be using? And
electric toothbrushes are big, and whitening, and we're happy to talk about that.
Let's touch on that, because one other part of gum disease and oral microbiome is people brush too hard, right? So let's come back to that and say, why are people brushing so hard, and why are you such a big fan of some of the new companies that are out there, like electric brushes out there? There's even one that you did some work with a little bit. I have no problem plugging them because they're a great company.
Yep.
But let's talk about brushing hard. I just want to share a little personal anecdote. I've had my personal dentist, Dr. Rosita Roshian, on the podcast before, and just realizing that she was like, oh yeah, you're right-handed. And you like, when I first met her, like, oh yeah, you're right-handed and you brush too hard. And I'm like, oh, what, how do you know? You have gum recession on your right
One
side.
yes.
And you just, do that sawing motion and you're brushing too hard and, you got to chill.
It's the biomechanics of it. And it's very observant of her to notice that, because there is a difference between right and left-handed.
Right. And she's like, you're going to be at bigger risk of gum recession and teeth sensitivity.
You may need a graft, tissue graft, right?
All sorts of other challenges are there. So just talk a little bit about brushing too hard.
So it's how we brush. I mean, if you watch any typical movie and an actor is brushing, you'll see this sawing motion. You'll see that they, in all the TV ads, we've been brainwashed to put all this toothpaste on our toothbrush. The other factor is how often you replace your toothbrush head. Those nylon bristles are polished and end rounded. It's a process that they call end rounding, and they're smooth out of the factory. But after a while, you're taking nylon up against enamel. Enamel's the harder surface. You're wearing down the nylon, and the nylon becomes very abrasive. So you really need to replace your toothbrush, I would say, every month.
Every month?
Yeah. I mean, the standard seems to be 3 months now, but for a long time we weren't discussing anything. It was when the little blue indicator would go down to a certain point, or when your bristles were, angled outwards. I would, just to be on the safe side, your teeth, that's the last set you're going to get.
That's it.
And don't overbrush, and don't brush with a very worn toothbrush. And there are companies now that will send you a toothbrush head.
Yeah.
Automatically, and that's wonderful.
There's one that you were associated with, Quip.
Yeah, great toothbrush.
Is that a good solution for a lot of people that are out there?
Absolutely. Small, portable. Don't overthink your toothbrush, but be careful in how you brush and how often you replace your heads. That's the key.
Yeah, I think their toothbrush is great. I'm not sure about their toothpaste, but you've given us a bunch of other options that are out there for the toothpaste that's out there. Okay, I want to go back to your book. So inside your book, you have a 3-step program for improving sleep and overall health for the 8-hour sleep paradox and people looking at that. Would love to just cover those 3 steps, because I know we've kind of already covered it in some of the things that were there, but just as a recap, because sleep is so important.
It is so important. And I wish I had had this knowledge in my journey through treating my sleep apnea. It would have been much easier. But the first step, and it's probably the most important step, is to recognize that it could be you. I know a lot of patients that are still telling me they don't have sleep apnea, but I know they do. And that's difficult. And typically men. Women are our best patients, and when a doctor says something to them, they will say, you know what, I'm going to look into that and get tested.
There's almost this like weird pride that sometimes people have when it comes to sleep. Like, what are you going to tell me about sleep? Like, I know how to sleep.
Exactly right.
And you don't want to admit that something is off. I've noticed that a few times.
Yeah. Well, sleep is innate, but it's not guaranteed. And we all think we're good sleepers. And being able to notice, I mean, we come from being children and we sleep like babies most of the time. And then, if our sleep changes a little bit, those changes are so small. Plus, we're not conscious while we're not there to be able to analyze our own sleep. You cannot verify your own sleep. I keep saying that to people. You cannot be the decider of who tells you whether, you can't be that person. I sleep well, I don't sleep well. I was that person. I felt I slept well. Obviously, I didn't. I was having 12 interruptions per hour. So that first step is the diagnosis part of the 3 steps, and that is. But before you get a diagnosis, you have to be willing to get the diagnosis. You have to be open to the fact that you may have sleep apnea. Your father may be snoring. Your mother may be snoring. They may have high blood pressure, or
you simply just wake up with a dry mouth.
Exactly.
Or you're constantly getting up at night.
Right. Or you're napping, or you're getting up at the middle of the night and going to the bathroom. That is a comorbidity of sleep apnea.
We're designed to go to sleep and wake up and feel, there are morning people, there are evening people, but you're designed to wake up in the morning and feel rested.
Exactly. In my case, I was very good at going to bed late. I'd get that second wind. I was a night owl. I could stay up to 1 or 2 a.m., get a lot of work done, get up the next morning at 6 or 7, but I was burning the candle at both ends, and my adrenal glands were picking up all the pieces. And you can only do that for so long. But if I had known earlier that was happening, I would have gone to bed earlier. I would have solved my airway issue, and I would have do what I do now, and I would just get up without an alarm. The best time to set an alarm is when you go to sleep. Make sure you go to bed at the exact same time every night. Typically, that will solve a lot of problems.
Sleep hygiene.
Sleep hygiene. That's the number one sleep hygiene tip I can give, is just set that alarm. Mine's set at 10. My Oura Ring will remind me as well. There are a lot of apps that can do that. And also give in to that tired feeling. But if you're napping, My wife was very proud of the fact that she could sleep on trains and planes, and she traveled a lot early in her career, and she could sleep in a matter of minutes anywhere, at the dentist, getting her hair cut. That is sleep latency, and that is a severe issue. That is nothing to be proud of. It should, one of the things there's one thing I didn't like about treating my sleep apnea. It now takes me about 12 minutes to get to sleep, but that's normal. That is sleep latency. That's how long it takes you to wind down and for you to get into that first stage, that first 5% N1 stage.
So it's interesting because I've always fallen asleep very quickly. I have both done mouth taping and not done mouth taping, and I haven't seen an extreme difference.
Right.
My sister's doing it right now too, and I think you guys even sent her some mouth tape.
We did.
Thank you so much for that. Yeah. And she's noticing a big difference for herself.
Right.
I did have a shift in my dental structure, and I started having a lot of TMJ, and I was biting my tongue a lot at sleep. At the same time, my dentist recommended that I go on Invisalign to fix my bite that was showing up because my tongue was kind of pushing out on my teeth.
Right.
And for the first time, I would have dry mouth. But since I've been on Invisalign, that's kind of gone away a little bit. Right. I think it's helped a lot.
Oh, Invisalign can help in those areas, definitely.
Right. It's almost like a mouth guard in a way for that. But I do wake up in the morning rested. But you're saying there could be some sleep issues there.
It's possible because you only know what you know. I mean, your baseline. What is your baseline?
So for me, what's the answer? Should I go do a study?
I would do a study.
Okay.
Yeah, absolutely. Everyone needs to get that study. We will pick things up on that study.
Right.
And even if it's a perfect sleep study, then at least you have a baseline because your sleep will degrade over time. It would be nice to know exactly how long your brain is in delta wave sleep for. That's an important thing. That is the most important stage of sleep. And it would be nice to know what that number is. That's an important number. The Oura Ring and other testers, they extrapolate from the data. I'm not sure how accurate it is, but I can use it from day to day to compare one day to another, one night to another. But to know that is key. If we know what happens in delta wave, the liver, the brain, everything's fixing itself, wellness, happiness, fitness, no cravings for crazy foods during the day, the ghrelin and leptin hormones and all that being affected, all of that. If we could just know and have that peace of mind that we are getting deep sleep, then you have really nothing to worry about. Why not know that number?
Yeah. Well, that's a great recommendation. Right. I want to toss it. We were going through the three, and you kind of talked about the first one. Yeah. Before you do that, I want to toss in two of the things that I've seen have made a huge impact on my sleep. We talked a little bit about it with Sean Stevenson when he was on the podcast. Anybody interested can go listen to that episode. Both of these episodes work harmoniously because we didn't really talk about sleep apnea with him and our dental health and everything. And this is really something that you've been a big champion and advocate for. So I want to thank you for your work in this space. You're really raising a lot of awareness. So temperature has played a huge role.
Yes.
I know that when my room isn't cooled down or when I don't use, why am I blanking on the device that I use? It's a pad.
Bed-it? It slips underneath the mattress?
It's not Bed-it.
No,
there's Bed Jet, which I tried for a little bit, but I needed something a little bit more cooler.
Right. It's not the Chili Pad, is it?
Chili Pad. That was. I think the name was changed to something else.
Yes.
But yes, the Chili Pad.
Yeah, which is a very intriguing product.
And it really helps a ton. I have no affiliation with them at all.
Yes.
But I noticed that if I sleep and the temperature is off, it significantly disturbs my sleep.
Our core body temperature needs to drop a few degrees for us, for half a degree.
And men are a little bit different than women, just like big picture, and every person is a little bit different.
Yes.
So sleeping with a Chili Pad has made a huge difference for me.
Yeah.
The other one, which I notice a lot more for, and I've been recommending to my friends, is an air filter at night. A lot of people who have trouble breathing through their nose, I find that there's this one category of people that they're overall pretty okay, except their just nose is stuffy a lot, but especially at night.
Yes.
And they could be having off-gassing from their bedding. They could have other furniture. They moved into a new house. It could be paint, carpet.
Dust, mites.
Indoor air is typically so much worse than outdoor air.
Right.
So often I encourage people to open the window if they're in a place or to just get a good HEPA air filter.
Yep. Keep it on at night.
Keep it on at night.
Little white noise doesn't
hurt.
White
noise. It's soothing. And for one of my close friends, I sent him an air filter. There's a company that sent me a couple of them. It's called Air Doctor. Again, no strong affiliation with them, but just a cheap air filter that works that we've recommended a few times. And that's been a big help for some friends that I know.
Here's the problem. When you lie down, if there's inflammation in the sinuses, for example, when we take out a tooth, we tell patients not to lie down that night, because when you lie down, all the blood goes to that area. The blood pressure gradient to that wound changes the inflammation. And nasal inflammation is such that, so that when you lie down, I don't know if you've noticed, you become more congested when you lie down. So in addition to that, the allergens and the things in the air that contribute to the inflammation, it's just made worse by lying down. Also, we need to sleep with lighter covers.
Right.
Or no covers. I don't know if you've tried that, but try getting used to sleeping without covers. It's difficult because we're so used to it. But I guarantee you will notice a difference in the quality of your sleep.
And are you saying that because of the temperature? Are you saying that because of the material that it's made of?
The temperature, yeah. Okay. It could be, down. I recently got rid of all my down comforters. We use a kind of a bamboo product now in our comforters.
And is the down concern because of like dust mites and that sort of thing?
Yeah, right. Yeah. I was reacting to the down. So, but try sleeping without covers. Not an easy thing to do. And, clean your sheets a lot, boil them, high temperature. The Europeans are good at that. I don't know.
Boiling your sheets. I've never heard of this.
Well, their washers run at higher temperatures, the water. We just use the hot water tap. Yeah. And your hot water tap is set at whatever. Hot enough maybe for a shower. So, but boil your sheets. That gets rid of all the...
So how are you doing this at home?
Well, I have a German washer and it heats the water. And then cooks them. And they smell different. Sheets, I don't know, when you travel to Europe, you just got back, I think. Yeah. That's something I've always noticed, even from a kid. The sheets smell and feel different in Europe.
Unfortunately, I was staying at an Airbnb and they were very generous with the fabric softener and the Febreze.
Oh, gosh.
And usually I email them or my assistant emails them ahead of time and like, no fabric
Febreze,
softener.
Exactly, I
no
agree.
Febreze.
Right.
But I'll have to pay attention. I'm headed to Italy in August with my family.
Sheets are good.
So I'll have to
sheets are good
in
Italy. They are. They're good at boiling their sheets.
So we took a little diversion. Let's go back to the 3 steps that are there. The first step is just recognizing that you're a candidate and that this is something to pay attention to.
Right. Yeah. Second step is the treatment, and that is a difficult, tedious step for a lot of people. And there are essentially 3 categories. There's surgery, there's the CPAP, APAP, the mask that people can wear, and the oral appliance. And when people hear that, they don't like any of those. Most people would prefer the oral appliance because they've heard that's more comfortable and more doable. They can travel with it and it seems easier, and there's no stigma associated with it. Because at most, your chin is just sticking out a little bit, but you can cover up what's inside your mouth. The CPAP, APAP, most people, I don't know why this exists, but they are deadly afraid of it, especially men. It's I don't know why, but obviously it's uncomfortable. The problem with the CPAP and APAP is that only 30% stick with it for the first year.
Right.
And afterwards, there's no follow-up. There's very little follow-up. I see a lot of patients. In fact, the bulk of my sleep practice are patients that have tried the CPAP, have failed using it. They either have sought me out or by chance, I've said to them, listen, I think you have sleep apnea. Do you want to get treated for that? And they go, no. I know I have sleep apnea. I wore my CPAP, I tried it for a few months or for a year, and I stopped using it. And that was 10 years ago. And there was no follow-up with this life-threatening condition, right? And so I right away talk them back into the APAP, CPAP. I make a deal with them. I tell them, we'll make the oral appliance. We'll get your airway partially open or fully open by using that device. And then the APAP will be that much easier. And also the machines have gotten better. So
now this is because I've never worn a CPAP. I've recommended so many people go get a sleep study.
Good.
And also one little anecdote is one of my dearest friends was wanting to make some lifestyle changes and lose some weight as part of that process.
That helps.
And he had plateaued for so long. And then finally I said, that sleep study that we had been talking about, go get it. You're a doctor and you're like a good candidate. He went and got it, just continuing down the clean eating diet that he had already started and using the CPAP. Those 15 pounds that he couldn't lose, they came off.
I hear that often, yes, and I see it often. And it actually happened with me. Once I was able to get control of my sleep apnea, I was able to drop sugar completely, go paleo, and the cravings are gone. It really is a hormonal imbalance caused by the sleep apnea that makes us, crave for these foods that are not good for us, because it's instant energy. But it's bad for your teeth, it's bad for your gut microbiome, and it's bad for your weight.
So one question for you. So when people are put on a CPAP machine that is helping them with their breathing, because I've never used it before, I've seen photos of them, and I know they've gotten a lot smaller. are you, in addition to that, mouth taping them?
It depends. If you're wearing a full face mask, perhaps not, but you do still want to keep the mouth closed. They have chin straps. That was the old way of dealing with that. But if you're wearing a nose pillow or a nose, if the air is only coming in through the nose, if your mouth opens, that pressure is released. The pressure is lost, and there'll be a noise that will actually wake you up.
Right.
So mouth taping can be used in conjunction with CPAP and APAP therapy. Absolutely.
So you went down the line of number 2, which is all these interventions and figuring out the right intervention for you. And the challenge of really working with somebody knowledgeable, because even in the instance of being recommended a CPAP machine or interventions, there's a lot of lack of follow through or physicians not checking in with the patient.
Right.
And so people try it and then they drop it because they think it didn't work, or it's too inconvenient for them to use.
Exactly. Or they can't afford it. And also, I see that happen often. Insurance companies sometimes don't pay for a CPAP, which is amazing to me, because they'll pay for, heart surgery, but they won't pay for one of the root causes of needing heart surgery.
That's number 2. And often number 2 is really a commitment to your health, because it takes a little bit of investigating and finding the right team. We often talk about you're the CEO of your own health. You got to build your team out. So that could be finding the right dentist.
And they have to be communicating with each other. All those team members have to be on board.
And it really requires you to be an advocate. It takes work.
Right.
But what's the alternative is often the question.
Right.
What's the alternative? So that's number 2, and you kind of outline it in steps inside the book.
Yeah, and I talk about surgery, and that's controversial, and it's not a fun subject. But in some cases, surgery is required. And there's also orthognathic surgery, where we have to break the jaw. An oral surgeon would do that, and you can fix the jaw by moving it forwards. But that's a pretty major surgery, and it takes a long time to heal from, and there are complications, and some of them are not very pleasant. But I would be careful with surgery. There's no reason not to try a CPAP, APAP first and see if you can just do that. And my advice there would be to find someone who actually cares about fitting that mask to you and trying all the different masks. The people that are very consistent and very persistent and tweak things at home and are good at adjusting things and tweaking things, they're the ones that make it through that first year and keep wearing it for the rest of their life.
Number 3.
Number 3 is verifying the sleep ability, and that is checking in. If you have an oral appliance, if you have a CPAP, the journey's not done. I mean, things will change. You may get allergies. You may gain some weight. Hopefully that doesn't happen. You're going to get older. That's definitely going to happen. These things change. That is, verify your ability to sleep. Make sure that you are getting the sleep you need. Do not ever fall into the trap of saying, you know what, the CPAP seems to be working great. The machine tells me I have less than 1 AHI per hour, and I feel good in the morning. You cannot make that assessment yourself, whether you're being treated or pre-treatment. Never have an opinion about your own sleep. Let someone else do that for you, and that's important.
Beautiful. So 3-step plan to put attention on arguably the most fundamental thing that we do on a daily basis besides breathing during the day.
Right, yeah.
Even more fundamental than, the more that I talk to functional medicine doctors, both at our own clinic, that Dr. Hyman and I have at the Ultra Wellness Center in Massachusetts, to physicians at the Cleveland Clinic that are part of the Center for Functional Medicine over there, it's just becoming so much more aware of the importance of sleep because of just how bad it's gotten.
Right.
Which
it's
is
wonderful.
Really great.
It's actually wonderful. Not that it's gotten bad, but that we seem to be more on top of this. It's a very salient and very popular topic. If you go to the internet and listen to podcasts and everything, a lot of people are talking about sleep, and it's long overdue.
Mark, for anybody who's listening who sort of feels like their sleep is just so messed up, and I'm sure you've talked to so many people who feel that way and they sort of feel a little hopeless, or it's just been something they've gotten used to their entire life. What do you want to share to that person who's listening right now?
You just said it. You get used to it. You get used to your life that way, being tired, sleeping, nodding off, not feeling great, not feeling very positive. And it takes a lot to get out of that state. And you could change your diet. You could, take a pill. You could take a lot of vitamins or a lot of supplements. You could exercise more, but you can't exercise and supplement your way out of this. You have to deal with your sleep. So you really have to be kind of first of all, you have to get out of denial about your sleep. And if there is a sleep problem, you have to be willing and open to thinking, I just need that sleep study. I need to get that baseline. And once I have that baseline and I'm fine, then I can move on to the other things. So my advice would be just to be open to it. So if someone tells you you're snoring, if someone tells you that you seem to be yawning a lot and you're tired or you're getting grumpy and all that, I would look to sleep. I would go there first and do something about it. Get tested. Just buying these little devices that you can wear, the watches and the units that you can glue onto your forehead and put on your fingertips, and you can start there. It's as simple as downloading a free app that if you can sleep in a room for a few nights alone, in a quiet room, and just record yourself. I've had probably thousands of patients do that, and they come back and they're shocked. Like my wife never told me I was snoring. And then they do that and they're like, oh my God, who was that? Was someone else in the room? It was them. I mean, that's the kind of denial we're dealing with in sleep. I was in that denial for a long time. I never thought sleep was going to be a problem for me, or was a problem, even though I showed all the signs of it.
Hey YouTube, if you enjoyed what you just saw, keep watching for more great content on how to improve your brain and your life.
Whatever is happening in the oral cavity, whether it's a bacteria, whether it's a products we use, any toxins, any insults, can have an overall impact on the rest of the body. It is not a separate entity.